Good morning and welcome to our webinar today on managing a relapse in MS. I hope you're all well. Today your presenter will be Bridie Phillips, and she's a nurse advisor here at MS Plus, and I'll be your facilitator, and my name is Peter Butler. Just an acknowledgement of country before we start. In the spirit of reconciliation, MS Plus acknowledges the traditional custodians of country throughout Australia and their connection to land, sea and community. We pay our respects to the elders past, present and emerging, and we extend that respect to all Aboriginal and Torres Strait Islander peoples here today. We also acknowledge our gratitude that we share this land today, our sorrow for the cost of that sharing, and our hope and belief that we can shift to a place of equity, justice and partnership. So just a little introduction on our presenter today. Bridie is a registered nurse and has committed the last 15 years to community health, predominantly in palliative care, pain management, and within the MS community. Bridie currently works as an MS nurse advisor here at MS Plus. The MS Nurse Advisor service, for those of you that aren't aware, is available for clients, carers, family members, and health professionals who have any queries about MS, symptoms, medications, general wellbeing. Anything that you have a query about, our nurse advisors are more than capable of answering any of those questions, and they are amazing. I sit close to both of them and they are great. So please do call them, call up Plus Connect at 1-800-042-138 and they will be able to organise a session with one of the nurse advisors. So I'll just introduce you now to Bridie. So thanks, Bridie, and I'll leave you to it.
Hi everyone, and welcome. Thanks for asking me to discuss relapses in MS. It is a question that my colleague Jane and I get asked a lot about. So I'm hoping today we can help clarify what a relapse actually looks like and what to do if you think you're actually having one. Now, I'm always aware when we're doing webinars that sometimes something will come up and you think, I would actually like to talk about that a little bit more in depth, because obviously, you know, we can't sort of answer all the questions, but I do encourage you to put your questions through. And if I can't get to answer them, we will get back to you offline. So you'll be able to speak to Jane or I. You can call into Plus Connect on the 1-800 number that Peter just went through. And we will look forward to having a discussion one-on-one if need be. So let's get into this. So what we're actually hoping to achieve today is, and I'll sort of put a bit of the program content here. So I thought we'd just do a bit of an overview of what MS is and the common symptoms. It's always really useful just to overview that. The types of MS that we generally talk about. Then we'll go over what is a relapse, what's a pseudoexacerbation, a little bit about being prepared and considerations, you know, around relapses, what potentially a neurologist will do. The big question a lot of people ask is, when do I go to ED? Then we'll talk a little bit about methylprednisolone, which is a steroid that is mainly used for relapse treatment and recovery from a relapse. Okay, so let's just look at this little picture here. And I always like to describe, and I guess when you look at this picture of the brain, spinal cord and nerves, it kind of does look like a stripped gum tree upside down. That's kind of how I sort of imagine what our nerve pathways look like. You know, you strip off the leaves and you've just got the branches and the twigs and everything. Very, very complex system. So what we know is that MS is the most common acquired chronic neurological disease affecting young adults, and it's often diagnosed between the ages of 20 and 40. And in Australia, it affects 3 times more women than men. And still, there's no cure. We've come a long way in understanding MS and how to manage it, but we still don't have that cure. We know there's no single cause of MS, but there have been many genetic and environmental factors contributing to its development. So what actually happens? So the body's own immune system mistakenly attacks and damages the fatty material that we call myelin. And that protection is around the nerves. The myelin is important for protecting and insulating nerves so that electrical messages that the brain sends to the rest of the body travel quickly and efficiently. So as the myelin breaks down during an MS attack, a process we call demyelination, patches of the nerves become exposed and then scarred. So that means that the nerves are unable to communicate messages properly and are at risk of subsequent degeneration. So basically, this means that the brain cannot talk to other parts of the body, resulting in a range of symptoms. So we can see loss of motor function, so, walking hand, fine motor, arm, loss of sensation, pain, vision changes, and changes to thinking and memory. So we'll just have a quick brief look at the common symptoms, because I'm sure most of you can relate to some of these. And this is actually an interesting slide, and I like it because it gives sort of the percentages of what a lot of people will experience. But when people are having relapses, we often see that these symptoms might exacerbate, or you might actually develop some of these new symptoms. Now, many of the symptoms are invisible, and they're often the most debilitating, like fatigue, pain, and cognitive decline. So we'll just briefly look at that, but you can have a look at that later on your handouts. It's probably important to know that there's probably three main sort of MS that we sort of talk about. So relapsing remitting MS, which is the most common form of MS, that's about 85% of people are diagnosed with RRMS. So it's known by flare-ups or exacerbations of the neurological symptoms of MS, also known as relapses, followed by periods of recovery or remission. So for some people, before a diagnosis of RRMS is made, they might be firstly diagnosed with what we know as clinically isolated syndrome, otherwise known as CIS. So that's essentially the first presentation of MS or the first relapse. But a diagnosis cannot be confirmed until a second episode occurs or new lesions develop in the central nervous system. And then that fulfills that multiple component of MS, which is why it's multiple sclerosis. So it's caused by an inflammation and demyelination in the central nervous system. But not everyone who experiences CIS will develop MS. And it's unknown why CIS develops into MS for some people and not for others. Secondary progressive MS is a secondary phase of relapsing remitting MS that can develop years to decades following the initial onset of symptoms. So this one is characterized by a reduction in relapses and a progressive worsening of symptoms. So more or less, if you look at this graph, an accumulation of disability over time with no obvious signs of remission. And this can vary, some people notice more progression, sometimes it's very, very slow and very, very individual for each person. Then we look at primary progressive, which is the rarest form of MS, and it's only diagnosed in about 10 to 15% of people. So what happens here is you get a progressive worsening of symptoms and disability right from the beginning without periods of recovery or remission. Relapses for most people are possible but not common. Additionally, there can be periods of plateau where progression can stabilise for a period of time. Okay, now that we've gone over sort of what MS is about and the types of MS and the types of symptoms, let's now focus on what is actually relapses. And it's a question that we do get asked a lot, and it can be really, really confusing. So the actual definition of a relapse, attack, or flare, as some people call it, and I love this picture because that's really depicts what I guess is going on. So we talk about a relatively sudden, over hours or days, episode of new or worsening or existing multiple sclerosis symptoms. And it must last for at least 24 hours, but more commonly for a number of weeks. And it must occur at least 30 days after the start of a previous relapse. And the other part of this is there must be no other explanation for the onset of symptoms, such as an infection or a rise in body temperature. So the immune system attacks the myelin covering of the nerves, causing inflammation and damage to the myelin. So you've got your demyelination. So the messages passed along a demyelinated nerve move slowly or are blocked, excuse me, causing a variety of symptoms depending on the part of the brain or the spinal cord that's affected. For example, you can get blurred vision, numbness, tingling, loss of balance, increased fatigue, weak muscles, bladder or bowel changes. But inflammation doesn't always result in a relapse. It can occur in a part of the brain not associated with symptoms, or the brain may be able to adapt rapidly and reroute the messages around the area of inflammation. So these are actually known as silent lesions and can only be seen using MRI scans. Increasingly, these silent lesions are being seen as both an important marker of MS activity and one of the measures which make up the NEDA treatment goal, so NEDA being no evidence of disease activity. If you're not sure whether you're having a relapse, you could wait a day or two to see if your symptoms improve before you contact a health professional. With time, you'll become an expert on your own MS and will develop a better feel for whether you're having a relapse or if it's just a day-to-day fluctuation of your symptoms. Now, if we compare this to a pseudoexacerbation, a pseudoexacerbation is not caused by new damage. It's brought on by other influences, for example, exercise, stress, heat, other infection, recent vaccination, hormonal changes like menstruation and menopause, or a urinary tract infection is actually the most common cause. And it usually subsides within 24 hours, or in sometimes when you remove the trigger. So for example, if you think you might have a UTI, I always advise going to a GP. If you get this sudden change in your symptoms, one of the biggest things is a UTI, and a UTI doesn't always present as you would expect in someone who has MS. So sometimes just going to the GP and eliminating, do an ear, nose and throat check, a blood count, and then a simple dipstick into your urine will tell us if you've got a urinary tract infection. So some antibiotics or whatever you need to do to clear that is going to take the infection away, and you'll probably find that your symptoms are a lot better. If it's a really hot day, air cons, cold water, rest, these are all the things that you can do. Sometimes if you are over exercising, you know, it's a warm day and you've gone for a 20k walk, which, you know, some people are still capable of doing, and you find that you've actually got to stay in bed for a couple of days because your muscles are aching, you've got an increase in pain and you're feeling pretty poorly, we need to back that down. And you may find after you've had a bit of a rest and a cold drink and air con that you are feeling a lot better. So some people can get a mild change in symptoms. So with time, you'll actually become an expert on your own multiple sclerosis, and you'll develop a feel as to whether you're having a relapse or if it's just one of these pseudo relapses. You'll be able to recognize whether, you know, you'll think about, oh, I'm really not feeling great. What was I doing in the last hour? Okay, or maybe I shouldn't do a 20k bike ride, or maybe I should have done that exercise in the cooler part of the day, you know. So you'll get to know that, and no one expects you to know it straight away. And I guess the biggest message is, if you're not sure, reach out and ask. Nobody minds being asked or giving you advice. So the thing is, though, with the mild change, if you're not sure whether you're having a relapse and it's really, really mild changes and you're coping okay, you could wait a day or two to see if your symptoms improve before contacting a health professional, but as long as you feel safe and supported. Okay, so let's get prepared. Not everyone has a lot of relapses, and but it's always good to be prepared. So developing a plan with your neurologist about what you should do and whom you should contact before you experience a relapse is probably important for yourself mentally as well, and being prepared. For example, should I call the office at the first sign of a relapse or within 24 hours of experiencing the symptoms of a relapse? So some of the things you might want to ask your neurologist or your MS clinic or your MS nurse, wherever you might be going, is, who do I contact in your office when I'm experiencing a relapse? Write down the name of that person and the phone contact. If I'm experiencing a relapse, when do I contact your office? When do I go to the emergency department? What information will you need from me when I call to report a relapse? How do you treat a relapse? And what are the potential side effects of that treatment? And how will I know if that treatment is working? And how do I follow up after the treatment? So it might be really good to have some of these answers sort of close by, you know, in a little folder somewhere about your health history, so that either you or someone in the family or a carer can actually refer to. But just keep in mind, every neurologist and MS clinic will have their own protocol. So it's really important that you have your answers specific to your doctor. So having a relapse management plan can help you cope better and minimize stress during this time. So keep your MS information and medication well organised and accessible, just like we just spoke about. So you might want to include the details of your medication and important contact numbers such as your neurologist, your GP and other healthcare providers. Identify areas that might require management during a relapse, for example, work arrangements, childcare arrangements, transport, or other commitments that you may not be able to manage if you're actually having a relapse. Prepare yourself emotionally. So a relapse might take you by surprise. We can't, and nobody can tell you if and when you're going to have one, and you might not anticipate its psychological impact. So it might be beneficial to access support from a clinical psychologist or a counsellor during these times, and communicate with your health team. As outlined in previous slides, it's important to talk to your neurologist and GP about relapse management and what to do during a relapse. So that can include who to call first, how long do you wait for symptoms to settle, which hospital should you go to if you need to be admitted. It's also helpful to take a copy of your diagnosis confirmation letter when you travel, in case you need to present to a hospital emergency department wherever you may be. Okay, things to consider. What can you tell your doctor when you call? So try to be as specific as possible while you're describing the symptoms that you've been experiencing. To follow some basic questions your doctor might ask you. So I always encourage to write notes down, because, you know, like keep little diaries, and you've always got it on hand for whoever might ask it. And so first of all, symptoms. When did they begin? The effect. How do they make you feel, these symptoms, and how are they limiting or changing your daily activities and overall function? Drug changes. Have any changes been made to your MS treatment plan? Has a new medication been added to your regime for a condition not related to MS? When are you due for your next medications, for example? Have you got an infusion coming up next week, for example? Have you recently given birth? This is an interesting one, postpartum information. So if you have relapsing remitting MS, you're less likely to have a relapse during pregnancy, particularly in the last 3 months, although the risk of relapse does increase in the first 3 months after the birth of your baby. So the individual patient's experience with relapses following any previous pregnancy is a good indicator of the risk of relapse following a birth. It's thought that the relapse rate is reduced during late pregnancy, in part because of the effect of the pregnancy hormones, particularly estrogen, which suppress the immune system to ensure that the body will carry a growing baby without rejecting it. We're very clever human beings. Interestingly, there's also some indication that treatment with a disease-modifying therapy for at least 1 year prior to conception reduces the risk and severity of a relapse following a baby's birth. Have you had any recent vaccinations within the past 3 months? So there's a possible link between vaccine and MS activity, and it's been suggested within 30 days following vaccination, given the possibility of vaccines enhancing the transition from subclinical to clinical disease after stimulating an immune response. So when we're talking about a subclinical disease, it has no recognisable clinical finding. It's distinct from a clinical disease, which has signs and symptoms that can be recognised. Immune response against vaccines may vary depending on the type of vaccine and genetic susceptibility. Life or stressful situation since you've last met with your physician. So we know that increased stress can trigger off like a pseudoexacerbation, and it's really important that they know how you're sitting mentally. Has any other health care provider other than your neurologist been involved in your care and treatment lately? Have you been to the GP? Have you seen a physio? Have you had some myotherapy? All of those things are really important for your neurologist to know. How would you describe your fatigue level, and how would you describe your mood at this point? Are you coping? Are the family coping? Very important things for your doctor to be aware of. What will your neurologist do? So your neurologist will do an examination to see what changes have occurred since you were last seen. They'll test for any signs of illness or infection to rule out that possibility. And if your neurologist determines that you're having a true relapse, they will discuss possible treatment plans. So steroids, rehab, they might discuss a switch of medicines and more than likely request an MRI. So although most relapses remit or resolve on their own over time, neurologists usually recommend treatment when the symptoms are severe enough to affect a person's ability to function normally. Early treatment might shorten the time to recovery. However, if you have less intrusive symptoms, as with a mild attack, such as numbness or spasticity, you and your neurologist might elect to use symptom management strategies only, reserving stronger treatments for a more severe relapse. If you have an illness or infection, this will need to be addressed before your symptoms subside. Your doctor will indicate if they wish to see you in the rooms, ED, or to wait and see. Don't panic. That's the biggest message. When to go to ED. So all this is going on, and I don't have MS, and I can imagine it would be very, very scary having a flare of symptoms, especially, you know, if it's been such a long time and you're not sure what's going on. When you do go to ED, it's usually because you're unable to carry out your activity of daily living. So you can't do your own tasks, can't get to the toilet, you know, can't carry out your daily household chores confidently. You might have an inability to stand on your legs. You might have lost some vision. Your pain might be unmanaged. You may have had some mental health decline. You might be living alone and you're just not coping, okay? The big thing, don't panic, reach out if you're not sure. You can call us, call your MS nurse, call your doctor, whatever you need to do to get that advice so that you're prepared and you know what you're doing and you're confident with what you're doing. If you need to, you can go to the emergency department via ambulance. If someone can take you in a car to the emergency department, that's great too. And you can always ask to get a wheelchair at the door. So let's just say they've decided to give you steroids. So the length of a relapse depends on the degree of inflammation and where it is. And if your doctor decides that you do need to have steroids, we'll talk a little bit about them. So the steroids will help the symptoms of your relapse improve more quickly. They will not have any impact on the ultimate level of recovery from a relapse or the long-term course of your MS. And they will suppress the immune system and reduce inflammation around the site of the nerve damage. So it is usually given, I guess the most common is the methylprednisolone, which is 1,000 milligrams daily for 3 to 5 days. Sometimes they'll elect to give oral methylprednisolone. It's a little bit of a tongue twister. 500 milligrams daily for 5 days. But of late, some clinics are also giving the IV methylprednisolone as oral doses at home following an IV infusion initially. And so it's really dependent on your clinic on your disease, your symptom load, and what your neurologist recommends. But in saying that, it's a great drug. It works really well. We know that it works really well, but it does have some potential side effects. They're usually mild and they usually go away quickly when you finish the treatment course. So the more common, the milder sort of symptoms are a metallic taste in the mouth, increased appetite, indigestion, stomach pain, stomach upset. One of the ones that I hear a lot about is the difficulty sleeping and the restlessness, like feeling like you're a cat in a hot tin roof. You can't sit still. An altered mood or mood swings, a little bit of confusion. Some people complain a bit of body aching, muscle aches and joint pains, headache and flushing of the face. I guess the less common things are things like rashes and acne breakouts. Some people have talked about palpitations, high blood pressure, a little bit of chest pain, swelling of the ankles, feet or hands, menstrual irregularities, changes in the level of potassium and sodium in your body. So they might actually give you some supplements if that is identified, and changes in blood sugar levels, particularly if you are diabetic, and that will require monitoring. Very, very rarely do we hear of something called avascular hip necrosis and infection. You need to let your doctor know if you're diabetic, because taking steroids can alter your sugar levels, and you need to let them know if you're pregnant. Some severe relapses require hospital admission with the possibility of rehab afterwards. It's good to know now, often the first IV dose is given in hospital, and they will often do the follow-up doses if it's available with hospital in the home. So you can have the next lot at home and not have to sort of go back in under that setting. Recovering from a relapse, this is very individual, just like your symptoms are individual and everything that's happening to you is individual. Whether you decide to take steroids or not, there might be other treatments that can help you with your symptoms anyway. So regardless of what's happening outside, whether you're having a relapse or a pseudo-relapse, it's always important to manage your symptoms really well. So that might include medication for MS symptoms, it might be physiotherapy, it might be occupational therapy to support you at work or at home, it might be neuropsychology or speech and language therapy, just depending on how this has affected you. For some more severe relapses, you might need some help from social services, for example, aspects of your personal care and preparing meals, home help, that sort of thing. Asking for help can be one of the hardest things to do, especially if you're used to being independently. But I can guarantee you, your family and friends are going to want to help. So please reach out. Everybody needs help at some stage in their life. So talk to them, get them to help. If they offer to come and vacuum the floors, yes, please. Can I take the kids for the afternoon? Yes, please. Would you like me to prepare some meals for you? Yes, please. Go for it. So talk to them. If you're going through a relapse, it's really important to bear in mind that it will usually settle on its own accord. And recovery is often a case of wait and see what happens. It's likely that you will feel unwell and more tired than usual when you're recovering from a relapse, and that can have an impact both at home and at work. So be kind to yourself and don't push yourself too hard during this time. Depending on the severity of your relapse, initial recovery can start around 1 month, but it can take up to a year to sort of get further gains and really get back on track. Your MS nurse or clinic might arrange a follow-up appointment, and that might be face-to-face or over the phone. And that usually occurs around 2 months after the start of your relapse. And it's important for this check-in, and it's an opportunity for your medical team to check how you are and for you to discuss other treatment options, particularly if things are still a little bit difficult. Work and study, you can arrange to work from home, temporarily reduce your hours, starting work earlier or later to help with your fatigue. Provide someone to take notes for you in a lecture or a meeting so you can focus on what's being said. Having longer or more flexible breaks during your working day. And emotions are often affected. You can often feel really emotional following a relapse. if you're finding it hard to sleep well, please see a GP to address that, because it becomes a real issue. And if you are finding it hard to sleep well, you might find it more difficult to deal with everyday situations, which wouldn't normally be a problem. And some medications, including steroids, can have a direct impact on your emotions as well. It's important to know that relapses can also have an impact on people close to you. Your family and friends may experience a range of emotions such as anxiety, guilt, or anger, and being aware that these may occur during a relapse, it's a completely normal reaction. But if you're all aware and you're all dealing with it, it can help you all to manage what is going on at this time. Are there any questions, Pete?
Great. Currently there aren't any questions, which tells me that you have covered off everything. And yeah, it was a very informative presentation. So thank you very much, Bridie. And
You're welcome.
I will keep an eye out for questions, but in the meantime, I'll just run through a few more slides. So I'll start with our services. And if you've seen our webinars before, you would have heard me go through these, but we do offer a lot of different services, and if you do have any queries, if you want help with or support with anything, do call Plus Connect, because we often, most of the time, can help. So I'll run through a few. We offer allied health services. So we have occupational therapists, we have physiotherapists, exercise physiologists, and social workers as well. So if you want or need any of those, please do call. We offer NDIS support. We help with NDIS plans and any support you may need through that process. We have employment support. So our employment support service, they're amazing. They can help you once you've got the job. If you have a job, they can help you make adaptations at work, or they can help you with things like disclosing your diagnosis at work, or they can even help you get a job, and they can help with things like resume writing and things along those lines. We also have wellbeing and peer support. So our peer support sessions, they get a lot of good feedback for those. People find them very beneficial. So if you are looking to find someone in a similar situation, or you just want to reach out to chat to someone, please do inquire about our peer support sessions. I've had a few questions come in, so I might just read a few out while you're there still, Bridie. So should I go to my GP if I'm having a relapse, or should it only be the neurologist?
Personally, I would always, given that if you think your symptoms have changed and you're not sure, it's always worth at least a GP telehealth. But I would prefer you went straight there, just in case it is something like we spoke about, urinary tract infection. It's a simple dipstick test to check, and you know, getting onto some antibiotics or something might just clear that up and, you know, reduce your symptoms fairly quickly, you know, once they sort of kick in. Or it could be that you've got some other infection, ear, nose and throat. It could be any number of things. You know, sometimes I would actually even suggest doing, you know, if you haven't had a blood test for a while, check your cell counts, do a blood pressure check, you know, just a general, and then the GP can say, well, actually that all checks out, and then we can go, all right, and then they can help you actually work through, you know, what have you been doing? Could it be some of the triggers that we were speaking about that could work it out? And then they can give you that advice. So I guess it's another piece of mind. And then if they say, well, actually, I am a little bit concerned this might be a relapse, let's get onto your neuro, or, you know, sit and wait and ring them. So yeah, I would always err on the side of caution and go see the GP first.
Great, thank you. Just a couple more. So I have here, can you have relapses in all types of MS? And how long do relapses last for? Days, weeks, or months, usually?
Well, that's a really good question. How long they last for is a really difficult question to answer, because that's a really individual thing on everybody. So if we go back to the slides on what the different types of MS are, you can have an exacerbation of symptoms regardless of what sort of MS you have. So, you know, in terms of the triggers, you know, even if you've got primary progressive MS and it's a stinking hot day and you know, you've had your carers in and you've done had a shower and a lot of activity, and then you're feeling extremely fatigued and you're buzzing all over. Well, I guess potentially we could call that, you know, a pseudo relapse. But if you experience anything different, regardless of what sort of MS you have, and you're not sure, reach out and speak to someone so that we can actually nut out what's been happening, where you are, and sort of make some calls around what you should do next.
And I've just, on pseudo exacerbations, I've got another question here. Can they last for up to a month, or are they generally shorter?
A pseudo exacerbation will repair fairly quickly. Even after a urinary tract infection, if you're on antibiotics and you've done all the things that you do to clear a urinary tract infection or whatever infection it is, you would expect that a fever would drop down within a couple of days. And therefore, the general definition of a pseudo exacerbation is that it lasts only 24 hours or until the trigger's removed. So if you're still experiencing a change in symptoms or an exacerbation of symptoms a month down the track and it's been 30 days since the last one, then you really should probably report it and decide what you're going to do with it.
Great. And a couple more, we'll get to them just quickly. If I have a relapse, does it mean my DMT isn't working?
Sometimes. Some people can have a relapse. It depends. Again, this is an individual thing. So if you are having a relapse on a drug, sometimes they will keep you on the same drug depending on the severity of it and in what context it is and what's actually happening. However, if this is something that is quite a severe relapse, and when you've had several of them on a particular drug, it is one of the triggers that they will talk about a switch of medication. So again, it really depends. For example, someone who might be, say, on a drug and they're just about due for their infusion, just say they're on one of the infusions, just about due for an infusion, it may be that they're having that little bit of period before where they're going into a bit of a lull before their drug triggers back in. They won't necessarily swap that drug at that point. It's really, you know, they weigh up kind of the benefit that you're getting from it and has the drug been really working. They look at all of those sort of things. But if you're on a different type of drug and then they do an MRI and they see new lesions, for example, when you're having a relapse, then they might say, okay, well, we're developing new lesions, this drug isn't doing its job, and then they might consider a change. So if you are having a relapse, yes, it's important that the neurologist knows about it and can make that decision, but not always change, but it is one of the flags to consider it.
Okay, and how long does it usually take for steroids to take effect?
Oh, they're pretty cool. Steroids, the steroids might actually, that's a great question actually, and I'm glad someone asked that. When you first have them, often people will say they feel like they've been hit by a truck and they feel worse for up to the first week. Because it's really having an effect in your system. And then after that first week, we often find that it starts to kick in and you start to feel better. So I'd usually say to someone, wait for the week and then hopefully it will improve. It's a bit like if you have an injection of steroid into a joint, you know, if you've got a sore joint and someone sticks a needle of steroid into it, and it hurts like hell for the first little while and, you know, you really feel uncomfortable. But once it actually starts kicking in and taking the inflammation out of that joint, it starts to feel a bit better. Well, it's a similar thing to the inflammation around the nerves. So and that's why when we're talking about some of the side effects of methylprednisolone, with the, you know, feeling like you've got joint pain and aching pain and you feel like you're a cat in a hot tin roof and you can't settle and you can't sleep and your diet's all up the creek, it's all part of the process of the steroids kicking in. So often it is about a week before, and then you've just got to let it work its way over the next few weeks after that.
And well, we've got two more. I think we have time for these last two. If I have a minor new symptom such as numb toes, do I need to contact the neuro or just wait until I see them next?
Numb toe. So a new symptom of, was that Pete? New symptoms of just numb toes. Haven't had them before, I'm gathering.
Yeah. Yeah.
Okay. Any new symptom, keep an eye on it. If it's just mild and you're still functioning okay, this is where you can potentially sit and wait for a couple of days and see what happens. But if the numb toes turn into completely numb feet and you are struggling to stand on your feet, or you notice some other symptoms occurring as well, particularly if you've never had these symptoms before, I would then contact your neurologist and let them know what's going on so they can make a fair call as to what to do next.
And this is the last one. I've been on 10 milligrams of steroids for 2.5 years. Because if I don't take them, I can't move because of pain. Is this bad for me?
Long-term steroids can have a lot of different effects. And if it's for pain, can I suggest whoever has sent that question in, I would like to talk to them offline, because I'd really like to explore what is actually happening in terms of the pain and what the other options potentially might be. Is that's a bit of a complex question. Look, some people do need to be on long-term steroids for multiple diseases, and we're not just talking about MS, but there are a lot of other options for pain management that would be really great if that person could perhaps identify themselves to you, Pete, and we can organise a service request if they would like to.
Yep, and we can work that out after this webinar today for sure. So Thank you everyone for their questions, and thank you Bridie for your wonderful answers. And I'll just quickly run through our resources that we offer here at MS Plus. So we have a podcast series which we try and publish in every month or so, and that has most topics you can think of. So around about MS to your sort of health and well-being and things like meditation. So go and have a look at that, and you can access our podcasts at anywhere you'd usually get your podcasts. If you already do listen to podcasts, so Spotify, iTunes, there's a few others I can't think off the top of my head, but also if you do have an iPhone, there is a podcast app which you can access it there as well. So we have an In Touch e-newsletter that goes out. If you don't receive that, please get in touch with us. And we have our webinar library as well. So on our new website, we have a resource hub where you can access all of these podcasts and webinars, and we do have some written articles as well. And please do follow our social media accounts, because we do run live events on those, generally on Facebook. So please do feel free to contact us if you have any queries, if you want some more information, if you need support or help with anything. Plus Connect are the people to call, and they can then refer you on to different services and different people in the organisation. So that number there is 1800-042-138, or alternatively msconnect@ms.org.au for emailing. And there's our website there, and the times to call preferably is Monday to Friday, 8 a.m. to 6 p.m. and you will get an answer around that time. And if you can't get onto us, we will get back onto you very immediately, but that is unlikely that we won't answer. So thank you very much for today, Bridie. A very informative session, and I hope everyone got a lot out of it. So thank you everyone for coming, and thank you, Bridie, and we'll hopefully catch you next time.